Welcome to this evening's presentation titled, What's the Quality of Air That You Breathe? My name is Linda Harvey, and I'm pleased to be your presenter. As we get started this evening, we would like to thank Health First for their support of this presentation. The average person at rest takes about 16 breaths per minute, which means we breathe about 960 breaths per hour, or just over 23,000 breaths per day. How many times a day do you think about your breathing? Well, if you're like me, it's not until I have a cold or I do some strenuous activity and become winded. However, we all know breathing is a 24-hour-a-day activity. And now a little virus called SARS-CoV-2 has caused a lot of people to become more aware of our ability to breathe. This session focuses on the quality of air you breathe in your dental practice. During this session, we'll discuss the relationship between air quality and disease transmission. We'll review recent findings on air quality and airborne transmission of COVID-19. We'll also identify current trends, recommendations, and regulations. And lastly, we'll examine strategies for air decontamination and improving air quality. At a high level, the quality of air, both indoors and outdoors, has been monitored and regulated for many decades. And when I think about outdoor air, I think about smog control or pollen reports for those who have allergies. In the past, when I was thinking about indoor air, I used to think about secondhand smoke in restaurants and other businesses until many states began to regulate indoor air smoking. Then in more recent years, there's been a greater awareness regarding indoor pollutants such as mold, carbon monoxide, and radon, just to name a few. One thing we should all keep in mind is the fact that according to the Environmental Protection Agency, the air in our home and offices can be 2 to 5 times more polluted than the outdoor air. Now, I have to admit, during my practicing years as a hygienist, I never gave much thought to the quality of air in our dental practice unless it was either too hot or somebody burned the popcorn. And now that topic is front and center, and in many ways, it's like a blinding flash of the obvious. Air quality specifically matters to us in dentistry, especially in regard to the airborne transmission of disease. You may recall there are 3 key modes of disease transmission. Let's think of them like the ABCs, if you will. First is airborne transmission. If you don't mind, let's come back to that one in a minute. Let's first address the bloodborne transmission, the second mode of disease transmission. Back in the 70s and 80s, there was a keen awareness and growing concern about bloodborne transmission of disease with the discovery of HIV and our subsequent learning curve about this virus. To protect healthcare workers from contracting a bloodborne illness in the workplace, OSHA issued the Bloodborne Pathogen Standard, which became effective in March of 1992. So the first time then was when we first heard the words personal protective equipment, because healthcare workers were now required to wear PPE. And among other requirements of this standard, we were instructed how to transport and handle contaminated sharps. So similar to adapting and adjusting to the bloodborne pathogen requirements back then, especially with PPE, we've been adapting and adjusting to our enhanced aerosol protection methods since then. The third mode of disease transmission is contact transmission. We know this can occur through direct or indirect contact with a contaminated surface, or even a sick individual, such as shaking hands with someone who may be contagious and they don't even know it. And we know that's possible with that 2-day window of time before someone really develops the symptoms, like they're asymptomatic, or maybe they have an asymptomatic case of COVID already. And then you end up touching your face and eyes after having contact with that individual. Interestingly, I'd like to share with you several studies that have been conducted about the number of times people touch their face every hour. One study published by the Journal of Occupational and Environmental Hygiene recorded subjects as they did office-style work for about 3 hours in a room by themselves. On the average, they touch their faces 15.7 times per hour. Now, this equates to touching one's face about every 3 minutes. There was also a similar study of students in South Wales, which showed that they averaged 23 touches per hour, with almost half of those touches involving contact between the hand and the nose, eyes, or mouth. Now, of course, we should not be touching our faces or anything else when we're gloved up and in the middle of a procedure, but it brings that to our attention when we think about contact transmission. And in dentistry, for us, it means maintaining top-of-mind awareness about properly cleaning and disinfecting those clinical contact surfaces to minimize disease transmission via contact transmission. So now, coming back to our topic of conversation is airborne transmission of disease. One of the first big discoveries about airborne transmission of disease that I remember learning about didn't even occur in healthcare. It was Legionellosis. It was discovered and named after a mysterious pneumonia outbreak occurring at an American Legion convention in Philadelphia back in 1976. You see, the conference was held in July that year, and it wasn't until after Christmas that the bacterium was even isolated. However, it wasn't discovered where or why it was occurring until the following year when another outbreak occurred. It was finally discovered that the bacterium thrived in the cooling towers of large buildings and was spread via air conditioning. So speaking of air conditioning, in addition, there was a COVID-19 outbreak in China in 2020 that was associated with the air conditioning in a restaurant. This outbreak involved 3 family groups whose tables were in close proximity. The airflow direction was consistent with the droplet transmission, and a total of 10 people from the 3 families developed COVID-19. While dental settings have appeared to be a low source of transmission for COVID-19, we still have to ask the question, is your office as safe as it could be? Because conceivably, COVID-19 and other airborne pathogens can be transmitted through the air by inhaling droplets from an infected person who coughs or sneezes. And speaking of airborne pathogens, here's just a partial listing of airborne risk in dental settings. While SARS-CoV-2 is top of mind, we can't forget about other airborne diseases that we've faced for years. And may I stress, for years in dentistry. Remember that cold or flu you caught and you didn't know where you contracted it? Well, over the years, I've seen many team members who come to work sick for various reasons. They don't want to let their team members down. They don't want to cancel patients, whatever the reason. But questions like that should cause us to pause and reflect in general about the quality of air in our work environments. So briefly, let's talk about the size of these pathogens, because the smaller the size of the particle, the more deeply it can be inhaled. So keeping that in mind, we remember that bacteria and viruses are measured in microns, which is harder to grasp the size of a particle that small. In dentistry, we think of millimeters, don't we? When it comes to measuring sulcus depth and everything else, we think of millimeters as our yardstick. So I'd like you to think of these analogies this evening. The opening of an eye of a sewing needle is about 1,200 microns, and a single strand of human hair is 70 microns. Both of those can be hard to see without your reading glasses or perhaps even your loupes, right? Well, looking more closely, no pun intended, let's look at flu. We see the flu, let's look at SARS-CoV-2 virus. We're all aware of that size of that virus is 0.3 microns. Influenza virus is right under 4.7 microns, and it's spread by larger particles that can travel up to a maximum of between 3 and 6 feet. Measles, that virus is around 5 microns, give or take a little bit. And I want to come back and talk to you about measles in just the next slide as well. Pertussis in 2019, the CDC reported 18,000 cases, and this little bacterium is 0.5 to 1 micron in length. Let's look at TB, ranging between 1 and 5 microns in diameter. The CDC told us that from last year, the TB data, there was a substantial decline in the number of reported cases of TB disease in this country. The COVID-19 pandemic probably affected the reporting of TB incidences. Last but not least on this slide is varicella. We know chickenpox is very contagious. If one person has it, up to 90% of the people close to that person who are not immune will also become infected. Now, I want to circle back to measles, for example, just for a minute, because just to use this as an illustration that while we're still in the middle of this pandemic, there's maybe more strains of COVID that will be coming. We don't know what the future holds. We're just preparing and staying as healthy as possible and following all the guidelines. So think about this, because you never know when something is going to crop up. We think of measles here as a childhood disease. And back in the 50s, before there was a vaccine, nearly all children got measles by the time they were 15 years old. And back in the 50s, anywhere between 3 and 4 million people were affected every year. 3 to 4 million people were affected. And there was about 48,000 hospitalizations on the average. By the 1960s, there was a vaccine. However, outbreaks can still be possible. And we saw this in 2018 in our country. There were 372 cases. These were 17 different outbreaks in 25 states. 97% of those cases were called import associated. That means that they were US residents who were returning home, or they were foreign visitors that we had. Of the cases involving US residents, those 337 cases, 76% were unvaccinated, 11% the vaccination status was unknown, and 13% were vaccinated. Also think about the fact that when we mentioned TB and the surveillance dropped in 2020, the measles surveillance also deteriorated in 2020, according to the CDC. And on top of that, measles worldwide hit a 23-year high in 2020. So can you imagine being in one of the countries that of course, everybody experienced the pandemic, right? But also having a measles outbreak at the same time. So there's just all kinds of ways that we have to be mindful of protecting ourselves from different airborne pathogens. So we could discuss any more of these in more detail. And it's important to remember that we've always had the potential for airborne disease exposure in dentistry. And COVID-19 just sheds a little bit more light on this risk now. So transitioning to our next objective, let's review the findings on air quality and airborne transmission of COVID-19. So looking at some of the findings related to airborne transmission of COVID-19, we see that the CDC reminds us that particles 5 microns and smaller may not settle for hours or even days. Looking at the next box, one of the first in vitro studies showed that SARS-CoV-2 was detectable in aerosols for up to 3 hours. And personally, I think this study was probably one of the ones that really contributed to our awareness more about air quality and our practices with this pandemic. And that same study showed that SARS-CoV-2 may live between 4 and 72 hours on hard surfaces. Of course, we know it was depending on what surface it was. This heightened our awareness about how we clean and disinfect our operatories because of the possibility of indirect exposure. And truly, that awareness extended from the operatory throughout the office, didn't it? I know many offices that were cleaning and disinfecting the patient's restroom after each use, along with high contact areas throughout the office. And I'm sure you did the same thing in your practice. Looking at the fourth box, several studies have confirmed that SARS-CoV-2 can be detected in saliva. And since some of the earlier studies in 2020, other researchers have jumped on board. MD Anderson, Yale, and Rutgers have also conducted research that yielded the same results. So we know that treating a patient who is SARS-CoV positive, that there is a risk to clinicians. And lastly, we see that SARS-CoV-2, remember, it's a single-stranded RNA virus, and RNA viruses have a higher rate of mutation than DNA viruses. And this continues to bear out with the number of variants that we've seen in the past 2 years. So these findings across the board play a role in how and what safeguards we should implement for optimum safety and well-being in our practices. And speaking of variants again, last year we quickly learned that the Delta variant was much more infectious than the original COVID-19 strain. We learned that with this variant, for every 2 people who contracted the original SARS-CoV-2 variant, COVID-19, 5 people were expected to contract the Delta variant. We know the symptoms of the Delta variant are much the same as the original COVID-19 virus. However, we found that the Delta variant grew more rapidly and to much greater levels in the respiratory tract. This chart on the right shows how Delta exploded in the US during the 3rd quarter of last year. Looking at from early June to early September, we can see that those orange bars that represent the Delta variant just kind of took over, didn't they? Just kind of marched across the field, thinking about the football playoff games this weekend. And if your favorite team is going to march across the field and win the game. So we just saw that was the major virus. But now we see, the story doesn't end with Delta. Just when some areas of the country seem to settle down with Delta cases, which we were seeing in Florida, which is where I'm from, South Georgia, and a few other pockets around the country where those areas had left the red zone. They had left the orange zone, which was a substantial zone, and we're down to the minimal and low risk areas from the lower levels of just the low number of cases. But then all of a sudden, Omicron popped up in late November, and we know it was first discovered in South Africa. The Omicron variant S protein is heavily mutated as compared to the other major COVID variants. It contains more than 50 mutations, including between 26 to 32 on the spike protein alone. So this means that some of the mutations that are there that are on the other COVID strains, but along with a few new mutations. And it's the new mutations that scientists and researchers must quickly figure out how this variant is going to impact us. And when you look more closely at the graphic on the right, it's a pretty interesting graphic because it's easy to read. It talks about the same number of mutations and so forth, and it talks about that with the Omicron. It mentions over on the right that the Delta was an aggressive variant in late 2020, which is coming up the case, and it became the most commonly spread variant around the world. But to show you how fast these pictograms and data can become outdated, this one has utterly changed in the past month because this graphic states that Delta is currently the most dominant variant. And we can see that as new variants continue to emerge, we must be vigilant about reducing our risk, which includes focusing on the quality of air in our practices. And thinking about Omicron a little bit further, we learned from researchers that Omicron replicates 70 times faster in human airways, but the infection in lungs appears less severe. At the time this article was written, the author raised the question whether a highly contagious virus like Omicron may cause more severe death and disease because it spreads so much faster, even though the lung infection appears not as bad. And thankfully, that does not seem to be the case at this time. And then there was a South African study that revealed that Omicron infections in South Africa are associated with lower rates of hospital admissions, lower disease severity compared to Beta and Delta, and that news is always welcome. I'd like to just give you a couple of quick stats from a news magazine that I was reading today, just briefly to interject here, that some Omicron stats, an average of 760,000 infections are now being detected daily. And this is triple the number of the peak last January. More than 147,000 people are currently in the hospital with COVID, which is some 5,000 more than last winter's high. But I think that we're not seeing as many individuals wind up in the ICU. And the story talks about here, the news report is that some of the hospitalizations are from people being admitted for other reasons, and then they end up testing positive while they're in the hospital. About 1,700 Americans are dying of COVID daily, roughly half that number from last year's peak. And that does align with evidence from Europe, and South Africa with their Omicron trends as well. So I think that's somewhat good information here in the end, right? So let's talk about what happened. Where do we see with this Omicron surge, all right? Let's take a look at what's going on with the Omicron surge here in our country. I apologize because this graphic is a little bit fuzzy. It's actually an archived picture on the CDC website dated December 14th. And I just mentioned that the other graphic had already quickly become outdated. So it's hard to believe the COVID status is changing so quickly that a month ago that this graphic is already outdated. So essentially all the orange sections of each circle represent the Delta variant. And the purple little slivers that you see in each circle represent Omicron. Now pay close attention at the next two slides because you're going to think this looks like a disappearing act. Just 2 weeks later, on December 28th, look at the change in our country. In 8 out of the 10 regions, Omicron cases are outpacing Delta. Only a couple spots like maybe, where it's neck and neck there in region 1 or region 9, but look where all the purple is. Region 7 was still a lot of Delta, but look at everywhere else. Just quickly, as I mentioned to you, region 4 is where we are in Florida, how we had seen some really low rates. We had dropped down. Most all of our counties were in blue and yellow, the zones, the lowest 2 zones for the number of cases, and how quickly it came right back up. All right, now hold on to your hats. Here comes the more current map. This map was updated January the 11th, and look at where we are. You can barely see Delta anywhere, except for region 7, 8, maybe. Now it's total reverse of what we saw back on December 14th. So hopefully cases are beginning to peak and we'll see things turn around. But just one more little look here before we do. Oops, oh, I guess I didn't put that slide in, so I'm sorry. We just kind of go back and just to reiterate the fact that, yes, this has changed so rapidly, and hopefully we are over the peak and we are moving onward and we can get past this particular variant and have a little reprieve by the spring, right? So looking at our third objective then, let's identify current trends, recommendations, and regulations. Airborne particulates. How long can they remain in the air? Let's talk about some of these requirements because when considering regulatory requirements, OSHA requires employers, and this includes us in dentistry, to conduct workplace hazard assessments. Please note that this was a requirement prior to the pandemic. But in the past, what I call the BC days before COVID, we primarily focused on bloodborne pathogen hazards. Now, doctors, you must evaluate the risk of respiratory hazards in your office. And when thinking about evaluating these risks, this is where we start. We start with these questions. And the first one is, how long does that particulate remain in the air? We've already mentioned the fact that particulates 5 microns and smaller may not settle for hours or even days. So what size particulates are you evaluating in your practice? The second question is, how far does the particulate reach when it's inhaled? And how deeply will it be inhaled? How virulent is it? That's the third question. And lastly, could it mutate? And is it antimicrobial resistant? When we think about the growing number of multi-drug resistant pathogens, it makes sense to implement multiple layers of protection in your operatory and in your practice. So let's dig a little bit deeper when it comes to aerosols. Let's keep those questions in mind and now look a little bit closer at your risk factors and conduct your hazard assessment based upon the aerosols generated during patient care. As you can see from this chart, the very first row, ultrasonic and sonic scalars are considered the greatest source of aerosol contaminations. So hygienists, please lean in with me now. This is important to bear in mind. Next on the chart is air polishing. The bacterial counts indicate that airborne contamination is nearly equal to that of ultrasonic scalars. This can be one important layer of protection that makes a difference with everything else we're going to talk about this evening is using the high volume evacuator. If you read the article from December of 2018, an entire year before COVID came onto the scene, there was a great article on aerosols in the dental hygiene operatory, and the authors were speaking about the fact that hygienists, that we need to have an HVE device with an opening of 8 millimeters. So that's one great way to reduce the source of contamination in the hygiene operatory. Now, doctors and assistants this evening, you all have been using HVE since the beginning of your careers, no doubt. So you've got that piece covered for that layer of protection. But this information is not new for us in dentistry. Dr. John Molinari has spoken and written about these categories since at least the early 2000s. So what's the difference now? Well, I think we all recognize that the answer is a little pathogen called SARS-CoV-2 and its cousins, or mutations, if you will. At the beginning of the program, we talked about just a few of the other airborne diseases that could be transmitted in dental settings. So ultimately, it's not just about protecting ourselves from COVID, yet that's a driving factor at the moment. Now, when it comes to regulations, what does OSHA say about aerosols and respiratory protection in dentistry? This slide is what I would call content dense. It has a lot of information in this slide. So let's take it slowly, and please allow me to read this to you and talk about these sections by section. Because this content is significant, it's mission critical to understand that OSHA states that surgical masks are regularly used in dentistry to protect mucous membranes of the mouth and nose from droplet spatter, but they do not provide protection, complete protection against inhalation of airborne infectious agents. Whoa. Among the increased precautions dental practices may need to implement, potentially for the first time, in order to comply with existing OSHA standards, is an OSHA-compliant respiratory protection program under the Respiratory Protection Standard. Wow. So what is OSHA saying here? So again, in our BC days before COVID, we relied on surgical masks for all of our procedures, didn't we? Well, we know that I can remember many offices telling me, we couldn't breathe with a level 3 mask, don't like a level 3, I'm going to go back to my level 2 or my level 1. So how many times do we want to kind of use a lesser quality mask for comfort? And now it's the fact that we have to really look at what's the next level of protection that we should be moving up to, just like we had to make that transition and adapt from even beginning to wear PPE back in the 90s. And trust me, I remember those days like they were yesterday. In addition, OSHA's general duty clause reminds us that employers are required to provide employees with a workplace free from recognized hazards likely to cause death or serious physical harm. Okay, so COVID may not cause serious physical harm as compared to, say, falling off a ladder. However, we should consider long COVID and other sequelae. And there have been a number of deaths related to COVID. Yes, the numbers have dropped, but we know that there are many people that died with the original strain and have died with Delta. So we know that that does happen. So OSHA will use this general duty clause to substantiate and help to support any areas where an office is not working through the changes to, continue with the different layers of protections. OSHA will use this general duty clause as a citation. And when you think about the OSHA statements from the previous slides, it really brings our attention to this hierarchy of controls from the CDC's website. This is the different layers of protection that we can put into our practice. And even 2 years into this pandemic, this graphic is just as relevant in the BC days as it is now. So we can apply the hierarchy of controls to help us reduce hazards in our respective practices. What I'd like you to do is to consider this analogy as the inverted triangle of safety controls in our practices. I'd like you to consider this as the safety controls. These safety controls, let me restart that. This inverted triangle of safety controls is to our workplace health and safety as a dental tooth chart is to quality patient care and patient safety. I definitely recommend keeping a copy of this chart handy because as you continually evaluate and improve office safety, these hierarchy of controls can serve as guideposts for addressing different areas of safety. Now you may say, now where do I get a copy of this? How do I find this copy? It's easy. I don't have a direct URL to share with you, but I will tell you that if you simply do a Google search a web search, use the phrase CDC hierarchy of controls. No doubt you will come up with a URL that will take you to the page where you can print it out and have a copy for your office. Super simple to find. But when you look at this hierarchy, believe it or not, PPE is at the bottom. It's the least effective, although that's what we've been clamoring for these past 2 years. Glove shortages, mask shortages, all kinds of things we've been facing. Although we recognize the importance of PPE, particularly in light of OSHA's statement about surgical masks not providing complete protection against inhalation of airborne infectious agents, which means that we should be wearing N95 respirators or higher in lieu of surgical masks when performing aerosol generating procedures. So moving up the hierarchy of controls, next is administrative controls. These types of controls generally include a combination of various strategies or techniques that will reduce risk exposure to a safer level. So think about things like training, policies, procedures, work designs. Those types of things will lessen the threat of a hazard to a worker. You see, administrative controls seek to impact the behavior of people rather than removing the actual hazard. And it's also more than just providing PPE. Several other examples of administrative controls are listed on the slide for you. This includes the COVID screenings that you're doing for everybody that enters your office per OSHA. So if you are not doing it or you stop doing it, we really need to reinitiate that, screening everyone, patients, visitors, vendors, guests, team members, to be sure that you're not allowing anybody who has COVID-19 or is suspected to have COVID enter the practice. Continuing to have everyone wear a source control mask. This is a requirement for patients, visitors, vendors, and team members per the CDC. And I know sometimes when I talk to offices about this, I can just see everybody rolling their eyes because they will tell me times over, oh, the patients are so tired of it. We're tired of getting beat up because the patients don't want to do it. We're tired of wearing source control masks. And believe me, I totally get it as well. However, when our patients and visitors enter into a healthcare facility, they have to follow the same rules and guidelines that we do. So continue to use your best customer service skills to explain that to your patients. We may be continuing to limit the visitors and guests that come in, and that's a great way to have a good administrative control. And I know offices that are leveraging teledentistry where possible. If you haven't stuck your toe in the world of teledentistry, I'm thinking of one particular office in which they use teledentistry for their myofunctional therapy visits. So that way the patients don't have to come in for the visits after they get all established into the program. They can do that via teledentistry. Well, the third hierarchy that we're going to discuss in this program, and the final one that we'll discuss, we're not going all the way up the top tonight, is engineering controls. Engineering controls seek to isolate people from the hazard. Think about engineering controls as some kind of physical change in the workplace that isolate you from hazards by either containing them in an enclosure or removing contaminated air from the workplace through ventilation and filtering. Ventilation and filtering have been long-standing health and safety controls in healthcare and particularly hospitals for decades. Well, we've all heard of isolation rooms, right? In hospitals, they've got isolation rooms for TB positive or COVID positive patients. But consider this scenario. Have you ever walked down the hallway in a hospital and passed by an inside construction area? So what did you see? Most likely there was a heavy plastic drape cordoning off the area, sealed meticulously with duct tape of some sort, and there may have been some special mats on the floor to reduce particles of dust that are being tracked, keep them from being tracked into the main hospital areas. You see, those precautions serve to isolate construction hazards, the dust particles in particular, from patients, employees, and visitors, and that's an engineering control. Now, short of doing something else in dental settings, what can we do? Well, I'm glad you asked, because that brings us to our fourth objective, where we will examine strategies for air decontamination and improving air quality. 3 specific strategies for improving the quality of air in your practice include ventilation, air filtration, and air purification. Now, based upon the definitions from the American Society of Heating, Refrigerating, and Air Conditioning Engineers, which is ASHRAE for short, because that's a mouthful, as well as the definitions from the National Air Filtration Association, consider ventilation in your office or in your building as the process of supplying air to or removing air from a space for the purpose of controlling air contaminant levels, humidity, or temperature within the space. As I mentioned, I'm here in Florida, so to me, it's us, all of us in Florida, in the Southeast, it's important that we have temperature controlled buildings that are comfortable in the hot summer months, right? So that would be an important part of our ventilation system. Next is air filtration. And this is the ability to obtain the level of particulate cleanliness required by any definition of air conditioning, and filter devices are utilized. So we know two things about air filtration. One is that your central heating and air conditioning system has filters, and you have to change them monthly or quarterly, whatever the protocol is, or how fast they get dirty, whatever your manufacturer's instructions for use state. And then we also know that there are freestanding air filtration devices, which you may have purchased during the crisis for your practice. The third there is air purification, which employs the use of proactive and continuous disinfection methods. In other words, air purification is more than drawing air into a device, such as with the filtration to capture particles, and the filtration also captures odors and some pathogens. But air purification is the process of putting molecules back into our environment that safely disinfect the air. But let's look a little bit further at the ventilation regarding your central heating and air conditioning system, or HVAC for short. We all like to have products and equipment that work efficiently and effectively, whether it's our dental equipment or our HVAC system, right? And I mentioned I live in Florida, so having an efficient HVAC system to keep it cool and comfortable indoors is a really big deal. So HVAC systems now are designed to have what's called a minimum efficiency reporting value, or MERV value. The MERV value rating is derived from a test method that, again, was developed by ASHRAE, the American Society of Heating, Refrigerating, and Air Conditioning Engineers. And then looking at what the Environmental Protection Agency says about MERV ratings, MERV rating is a filter's ability to capture particles between 0.3 and 10 microns. So what does all this mean? What is your MERV rating? So turning our attention to that chart for a minute, the chart is also from the EPA website. MERV ratings range from 1 to 16. The higher the number indicates your HVAC ability to filter smaller particles, as you can see from the chart. MERV ratings from 1 through 4 are like 3.0 to 10 microns. MERV 16 is 0.3 to 1% or greater. So you can see the big difference there between 10 microns down to 1 and 0.3. So depending upon when your building was built, you may have a MERV rating of 12, 14, or 16, or you may have something that's older, being an older building. I'd like to share a story with you about a practice in hopes that this will help you determine your MERV rating. So put this on your list of to-do this tomorrow, because it's just Thursday this week. A practice I know is located in a single-story building with other professional businesses, insurance agents, real estate groups, so forth. No other healthcare provider, just the dental practice. Not too long ago, they talked to their heating and air conditioning specialist and found out that the MERV rating on their building was 8. And that probably met the standards when the building was built, or which the building is 50 years old, by the way, or has been updated since then and met the standards at that time. Because you see, the majority of that building is not a medical complex or a hospital or healthcare facility. It's a business complex. So it behooves that practice to then look at different air filtration or air purification devices to add another layer to make their office even safer. So the second area that we talked about out of the three is air filtration devices. They typically rely on HEPA filters and they may or may not have other product features. It all depends upon the make and model and the brand that you are reviewing. To ensure we're all thinking about HEPA from the same perspective, HEPA stands for High Efficiency Particulate Air Filter. And that is as it's officially defined by the US Department of Energy. A HEPA filter is a type of pleated mechanical air filter. And this type of air filter can theoretically remove at least 99.97% of dust and pollen and mold and airborne particles with any size down to perhaps 0.3 microns in size. And the important thing is when you're reviewing and selecting air filtration devices, let's consider some of the strategies might be. You want to find out if it has a HEPA filter or not. And if so, what are the particle sizes that are trapped by the filter? Does it have carbon filters so it can help eliminate the odor? What's the frequency and maintenance of changing the filters for the device? What do the manufacturer's instructions for use say? Is the device intended for healthcare use? Specifically for us in dentistry, aerosol generating procedures. And have any kill claims that have been made by the manufacturer, have they been tested? So looking quickly at two on the market, and there are plenty of other air filtration devices, you may have something different. First is Medify. This brand, this company in particular, has several models. The particular model on the screen has a 3-stage filter, a pre-filter, a HEPA filter, and an activated carbon filter. The product information on the HEPA filter states it catches 99.9% of particles down to 0.1 micron in size. And the activated carbon filter helps eliminate odors. So those are some features of that particular brand. The other model was just a pure model. It states that a HEPA filter captures 99.97% of dust, pollen, dander, and smoke. This product information states that it destroys germs and bacteria with a UVC light. So you can see there are a vast number of differing features. So it's important to ask good questions when you're reviewing devices, because some of the devices are purchased at retail stores, some are at hardware stores, and others you may purchase from a manufacturer or an authorized distributor. So looking next at the third technology, which was air purification, this is a newer technology. This particular technology is one that's proactive and continuous. The Active Pure device featured here on the screen is one device that I'm familiar with that has this technology, and you may be familiar with a similar device. Or you may be wondering, what in the world is proactive and continuous technology? Well, some of the key features of this technology includes the fact that it continuously generates and releases molecules that seek out harmful pathogens. This technology uses oxygen and the humidity from the air to release oxidizers back into the air to kill the microorganisms. So essentially, it captures particulates that are not captured by an HVE, high volume evacuator, or your heating and air conditioning system. These products also have a high level HEPA filter. The Active Pure also has one of its devices that is a Class 2 medical device, although not the one that's pictured. That's not the device but there's another model that is a Class 2 medical device. That means that the company submitted information to the Food and Drug Administration so that the device to be marketed is as safe and effective and is substantially equivalent to devices that are already legally marketed. So a lot to think about with that. Look at what the independent research states that's been conducted on any chosen device that you have or that you may be evaluating. For example, in a University of Texas study, Active Pure proved to reduce up to 99.99% of pathogens, including SARS-CoV-2, MRSA, Candida, swine flu, and Legionella, and more. So ultimately, there's a lot to consider when evaluating devices, and it's about selecting the most effective device that will improve the quality of air in your practice. So as we get ready to wrap up and get ready for Q&A, if I didn't mention it earlier, I do see a Q&A question has come in. Please feel free to pop your questions in to the Q&A section. So as you compare and contrast features on various devices and models, let's keep some of the key points in mind. Again, be mindful of the different technologies on the market. And does the company for the product that you're looking at, does it have any research to back up its product claims? Does the device rely on continuous and ongoing activity, or is it intermittent activity? How many square feet does it cover? And oh my gosh, we didn't talk about that yet, did we? How many square feet can it cover? Look at what your device, either your current device or any devices that you're evaluating. How many square feet should this be used in? At what size room? That's important because in our dental settings, if you're placing a device that has just a small capacity into a larger reception area, or you're placing it into an open bay area, such as an orthodontic practice or a pediatric practice, then you're not going to have the efficiency that you really need to have. And you may need to have multiple devices. And then you get into a situation of where do you place these devices? Because when you look at what the CDC says, clean air should be coming in over our heads ideally, and then it should be drawn away towards the foot of the patient chair. So that way you're not having a purification device in the hallway behind the head of the patient where you're bringing out contaminated air from the operatories into the hallways. And you're kind of trying to keep it as contained as possible in our open door and open bay setups. And then is the device an FDA medical cleared device, all right? And what pathogens does it kill? And what are the particle sizes does it kill? Those are all important features. And last but not least, again, what are the maintenance requirements? You know, when you think about the multitude of devices that we have in a dental practice, everything from maintaining the dental unit water lines to the sterilization equipment to your pump and your suction, all those devices, now we're adding in multiple different purification devices. And when we do, it's important that we know what are the maintenance requirements. Is there an auto ship or refill that could be done so that way you don't have to think about ordering filters all the time and running out? You've got auto ship and you've got everything on hand. So always look at the manufacturer's instructions for use. And also please bear in mind that many devices may be suitable for home and general office use, but are they suitable for a healthcare setting with aerosol generating procedures? In the beginning of the program, we talked about how many times per day and per minute we breathe. So let's get ready to wrap up here and talk about Q&A. And the fact that we're breathing is 24 hours a day activity, we know that. So the quality of the air that we breathe is extremely critical. So as we wrap up, I encourage you to become familiarized with the basics of air quality within your practice relative to reducing risk. It's important to recognize that outbreaks will continue to occur and COVID is not winding down yet. I know we're seeing maybe some decline, or maybe we've already peaked with Omicron, but we don't know what's around the corner. And not to be pessimistic, but just to be prepared in life. Plus, there are existing and other future pathogens that we have to be prepared for. Always maintain the standard of care, maintain those safeguards, follow the guidelines, standards, and laws. And certainly, last but not least, research any technology behind the air purification devices that you're considering, whether you've implemented something before and now you're looking to upgrade, or maybe you haven't implemented something yet at all. But this way you can make the best selection for your practice by implementing proven technology. So I want to thank you for participating this evening. I think we've got some questions. Let me see how we're going to be managing those really quickly here. So I'm going to just look on the chat window here. Whoops. And look at some of these questions. Let's see. Any data on the ultraviolet light purifiers versus regular ones? So I'm going to see if I'm interpreting this right. So ultraviolet light, yes, we know about the UVC light, and it has to be within certain specifications, of course, and we have to be careful that it doesn't emit light into our environment. So it's not something we're going to be looking at because of the dangers for our eyes and so forth. So the ultraviolet light purifiers versus one that doesn't, I would say evaluate all the other criteria of the device and make sure that it has all the different features. And if it has the ultraviolet light as well, that's great. But if it has continuous and proactive activity, then maybe the ultraviolet light isn't the number one feature to look at. So I would also just say, before focusing strictly on a UVC light, look at all the different features, including active and continuous technology, to be sure you've got as many features as you can have on the device. So here's a question here. What is the protocol if you were in an office and there is no air purifiers? So one thing that you can do at that point is talk to your doctor, and doctors, if you're here tonight, talk to your teams, of course, and find out about getting at least a device for your own operatory. I'm going to say perhaps maybe you're a hygienist or maybe you're an assistant who's worried. So bring that up to the doctor, because when you look at that, the levels of the hierarchy of controls, it's important that we implement strategies all along that hierarchy. So have a conversation with your doctor or doctors about implementing as many strategies as possible, because I can tell you in a heartbeat, offices that implemented multiple strategies, their patients are feeling much more comfortable and confident about coming back in. And while many offices are seeing a great return with their patients coming in, we want to continue to be safe. Here's a question. What will we say to our front desk team that refused to wear a mask? Well, I think that is something, I don't know if that's from you, doctor, or from a team member, but that's something that needs to be addressed at the leadership level of the practice, because that is a requirement to wear a source control mask. That is a CDC safeguard. You know, we're held to these standards, and how can we expect our patients to not wear their mask when they're coming in if we aren't being compliant? I can tell you, I know when I'm making calls into offices, you know, I'm always wearing my mask, but as soon as I hit the front door, I can see somebody behind the desk quickly pulling up their mask because it's been below their chin. And so I would encourage them to realize that they are at risk as well, because when you think about the definition of close contact, that's exposure to a high-risk patient with 15 minutes or more. And so that 15 minutes doesn't have to be consecutive. It could be 5 to 7 minutes when they're checking the patient in. It could be another 10 minutes when they're checking the patient out, or maybe they're helping to do a consult. So they may have risk with being exposed to those patients early on. So let me see what other questions we have here. Okay, so one person asked a question about additional benefits of having open windows, circulating fans, in addition to having air filtration devices and purification. So I know that the CDC website does talk about that. I'm sorry I did not address that this evening, but having open windows, I did mention the fact that the EPA has alerted us to the fact that our homes and offices are 2 to 5 times more polluted than the outside air. So that's certainly one idea. Watch out for circulating fans. I know that when we look at particularly in dental settings with fans, team members get hot because you've got 3 people sitting close together. When it's a doctor, it's you and the assistant and the patient, or hygienist when it's you and the patient. So, and then the light shining down on you. So we typically, team members want to have a little fan kind of to keep them cool. But no, we can't have that kind of fan. So if it's a circulating fan that's drawing air outside, then I think that could possibly be fine. So I appreciate the fact that it's cold there where the windows, it's barely cold to even open the windows just a few inches in many areas. So maybe if you have a situation where you are traveling in your role, either a dental professional or medical professional, maybe you can have your own purification device that you take with you from location to location. That could be one option as well. Okay, one person volunteered that their team wears a particular kind of unit, so max air units. I'm not familiar with those. You may let us know. Are those an elastomeric or higher than N95 mask? They do have, the mask use in healthcare do have to be NIOSH approved if they're respirator masks. So that's an important feature to look at too. So question here, do I think that spraying Lysol disinfectant helps with aerosols? I have not read any research on it. It may help, but I want to share with you a thought about having the aerosols like that, adding more aerosols into your environment. For team members, that means you're going to be breathing that aerosol or any other spray disinfectant yourself throughout the day. And however long that lingers in the environment, if you're spraying a room for 2 or 3 minutes, trying to disinfect, quote unquote, the air, now you're going to be breathing it. And the patient coming in behind you with any lingering smell of whatever product is being used, if that person has allergies or asthma that could possibly trigger a reaction in them. I would say your safest bet is to stick with known protocols, such as looking at your MERV rating with the heating and air conditioning, looking at air purification devices, looking at other things you can do at the patient level with extra oil suctions and high volume evacuators and dental dams, for example. I have not seen any research with just using a spray disinfectant. So what about an office that doesn't do anything? So my heart goes out to you, and I think this will probably be the last question this evening. But there's one other one I want to address really quickly. What types of masks are OSHA compliant? So no air purification, no temp checks. It's kind of perplexing because this is something that's been required now for 2 years. We get asked the question a lot, is the CDC just a recommendation, or is it ordered, or is it a law? Please be aware that at least a dozen states, and I don't have the exact number, but there are many states in which the CDC 2003 guidelines and the recent ones have been adopted into the State Dental Practice Act. Georgia, I'm drawing a blank on some of the states now. I think Pennsylvania, I'm drawing a blank, sorry for the sake of time here. And that means that if you're not following the CDC guidelines, you are not following the State Dental Practice Act. And so doctors, you could be opening yourself up to any disciplinary fines if the patient should file a complaint about the practice. Otherwise, please do the best you can in your operatories. Consider purchasing your own device and wearing masks yourself and following all the protocols for yourself. And so last question, what types of masks are compliant with OSHA requirements? So thinking about that, we do have to use the ANSI standards, which is the level 1, 2, and 3. That's the first level of mask that we have for non-aerosol generating procedures. Up until SARS-CoV-2, we were wearing level 3 surgical masks for aerosol generating procedures, but they do not filter out particles down to a 0.3 size, and they are not tight fitting. So other types of masks that are compliant with the OSHA requirements are N95, surgical N95 respirator masks or higher. A higher means that they are an elastomeric or air papper, but the N95 respirator mask must be NIOSH approved to be used in healthcare settings. So I hope that helps. We have some questions that we didn't get to this evening, and I will check with our host and see with Viva Learning if we can maybe incorporate some of these questions into the podcast that we're going to be doing in the next couple of weeks. Thank you all for attending this evening. We appreciate your time for being here.